Good afternoon. We'll start our fourth session for the second day of 7th SSR. The chairpersons of this fourth session is Dr. Mohammed Bidawi. He's Associated Professor of Internal Medicine and Consultant Rheumatology at King Khalid University Hospital, Head of Rheumatology Unit at King Saud University, Rheumatology Fellowship Program Director at King Khalid University Hospital, member of the Committee of our Practice Guideline at King Khalid University Hospital, and Dr. Nabil Hakami, Consultant Rheumatology, Head of Rheumatology Unit at King Fahad General Hospital, Jazan. Welcome our chairpersons to start our session.
Thank you very much. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon. I would like to welcome you in our last session today about ankylosing spondylitis. Actually, we will have two virtual talks. First one about surgical management and ankylosing spondylitis, starting with Dr. Mohammed Khashab. Dr. Mohammed Khashab is an assistant professor and surgical consultant of spine at King Saud bin Abdulaziz University for Health Science and King Abdulaziz Medical City, Jeddah. So without any further delay, I would like to give the mic for Dr. Mohammed. Thank you very much.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank the organizing committee for this kind invitation. I will be talking to you about the surgical management of ankylosing spondylitis. I've got nothing to disclose with regard to the topic. Ankylosing spondylitis is a well-known complex disease that affects the spine mainly, and the group of symptoms and complications that does happen with this disease can be controlled and reduced if the patient is following up with complying with the treatment protocol. So the disease itself starts in the facet joint and the intervertebral disc space. The lymphocytic infiltration, when it affects the annulus fibrosis with the vertebral end plates, it does form the syndesmophytes, and then the final fusion of the spine gives the picture of what we call bamboo spine. The treatment of the ankylosing spondylitis focused mainly on identifying the disease and institute the treatment to arrest the progression of the disease and the activity. The deformity can be lessened by behavioral changes, like asking the patient to use a pillow instead of two to help align the cervical spine closer to the normal, and reducing the kyphosis, avoid sitting for a long time with the good breaks, and doing some stretching maneuvers early on with the start of the disease, like lying down in prone position to help straighten the back into a normal position, and identifying patients who has a possibility of a fracture is extremely important early with the development of a fracture. They are at a higher risk compared to non-ankylosing spondylitis, like a 7-fold when it comes to the spine, but when it comes to the lower or upper extremity, that increase doesn't exist. They are liable to get a fracture because of the long, rigid beam of bone that is formed by fusion of all levels, functions like a long bone, and the presence of osteoporosis, as well as the lack of ligamentous constraints, which helps in absorbing the energy when trauma propagates through the spine. It doesn't exist in those kind of cases of ankylosing spondylitis. So whenever a question of fracture is there, CT with a thin cuts is the ideal to answer the question. And we need to know that the cervicothoracic junction is at risk, which is plain X-ray is not helpful at all. You will not be able to visualize that area. And also at all the junctions between mid-thoracic as well as thoracolumbar and even lumbosacral, they can fracture. So CT will be the best modality. Around the fracture, the epidural vessels tend to bleed and form a hematoma called epidural hematoma, which can compress neural structure. The translation which may occur due to the long rigid beam of bone can cause more narrowing around the narrowed area with the epidural hematoma, compressing the neural structure, and can lead to catastrophic neurological deficits. This is a 67-year-old lady who presented to the emergency following a fall. She's a known case of ankylosing spondylitis. She had mid back pain, and upon taking an X-ray by our ER physician, they've noticed that mild fracture at the T6 level, and she was given a brace and reassured and went home. Within a month of agony at home with the severe back pain, she came back to the emergency room, and this time her daughter reported that the shape of her back, the mother back, has significantly improved prior to the trauma. And what happened is the extension fracture improved her alignment significantly. Fortunately, this lady, she remained neurologically intact right from the beginning till month after the initial trauma, and she was actively mobilized, which is quite impressive. The immobilization in such a patient usually has to be made in the pre-injury condition to avoid the hyperextension injury, and positioning the patient on a spine board like this patient is not the proper way of immobilization, but such a positioning can cause hyperextension injury, which can cause further neurological deficits. An MRI done for this patient, and you can see the high signal intensity at the disc level, as well as epidural space of the formation of a hematoma, and even the soft tissue ligaments at the back of the facets is completely disrupted. This patient is highly unstable. She would need a surgical management, but before we take her to surgical management, atlantoaxial instability has to be ruled out by dynamic flexion extension view, which can be there without a diagnosis. Intubation has to be made with a fiber optic intubation in order to maintain the alignment of the neck at the time of the intubation. And these patients do have a problem with their breathing, so pulmonary function is usually reduced with the process of the ankylosing spondylitis. So the care should be taken and discussion has to be made ahead of time with the patient and family. She would need a prolonged recovery and probably ICU admission post-operatively. This patient was taken to OR, and we did instrumentation above and below with the correction of the alignment, which she started it by herself actually with the hyperextension. So her alignment was corrected to 54 compared to the initial one, which was 85 degree of a thoracic kyphosis. And we decompressed the spinal cord and as well as evacuation of a hematoma. She did well for about a year with a full recovery post-operative back pain. 1 year later, she presented again to the emergency room and after a fall again, and this time she had a severe neck pain and a low back pain. CT scan showed a T6 fracture that goes all the way to the posterior element. And when you take an MRI, you can see how significant is the soft tissue disruption at the disc space, going and propagated all the way through the posterior element and the soft tissue, even at the muscle, you can see a high signal intensity, telling you that fracture is highly unstable. Lumbar spine showed lumbosacral fracture propagated through the disc as well. Then patient has to be taken for stabilization again with the correction of the alignment and fusion. And the same thing done at the lumbosacral spine with instrumentation through the pelvis going through the sacroiliac joint, which is already ankylosed as a part of the disease process. So adding screws to the sacroiliac will give you significant strength of the construct. 2 years post-op, she remained active and neurologically intact till now. Ankylosing spondylitis is well known for a deformity of the spine. They're liable to get what we call fixed sagittal imbalance syndrome, which is the patient will not be able to stand erect without flexing or compensating with the hips and knees. It's well known throughout the course of time, some creature like Archosaurus walking on 2 legs with a counterbalanced spine because of the head with the long neck at the front and the tail at the back gave that dinosaur the ability to walk due to the counterbalance mechanism. The primate bird as well, with the long neck and head at the front and reversed knee articulation, was maintaining the balance, and the same thing for the monkey with the long arms. So the balanced spine is extremely important to have the alignment. With the human, the alignment of the cervical lordosis, thoracic kyphosis with the lumbar lordosis can bring the alignment of the spine from the head all the way down to the lower limb with the sagittal vertical axis, SVA, to be right at the middle, taking the load from the top of the head all the way down on top of the pelvis to the lower limb. When we analyze the parameters, we look at the relation between the spine and the pelvis. We look at what you call pelvic parameters, mainly the pelvic incidence angle. We measure that by taking an angle from the mid-sacrum with a vertical line to it and connected with the hip center of rotation, which is the center of the head. So by taking that angle with the pelvic tilting angle as well as the sacral slope, we understand the relation between the spine and the pelvis. This patient is trying to compensate for his sagittal profile. So looking at him, the first look, you will see that this patient is aligned well. But when we ask him to straighten his leg, then he will lose the balance. So the first one, he was able to maintain the balance because of the flattening of thoracic kyphosis with retroverted pelvis and a hip extension with increased pelvic tilt and knee flexion, was able to maintain the balance. So if we take that balance off by asking him just to extend his knee, you will see that his balance is off. So the ideal, or what we call economical way, is to have a balanced spine without any compensation. The compensated gait, when we have the hip that is retroverted, hip extended, and the knee extended, knee flexion, patient can have a balanced spine, and that's called compensated gait. But when we have the whole compensation is going on, but still the alignment is off with the completely failed sagittal profile, that is in need to get some walking aid like this lady, then that's called uncompensated malaligned gait. These patients usually have an advanced arthritic hips due to the extension of the hip as a trial to compensate, and the arthritis will require a hip replacement, and when we do that, we put it in extension in order to cope with the whole global alignment, and that hip has to be modular in order to cope with that specific point of hip rotation. That patients with ankylosing spondylitis do get an advanced arthritic changes around the hip and sometimes get ankylosed. So those patients are indicated to go through a knee replacement as long as their quadriceps mechanism is still functioning well. So they would get what we call remodeled joint implant. So the implant usually have a survival of about 10 to 14 years, less than the normal people, but still helpful for improving their functions. And we need to know that these patients are at a higher risk for getting what we call heterotopic bone ossification, and they can even have an ankylosis even after joint replacement. So a close observation is needed. When it comes to the spine, correction of the alignment is important and a target for any correction with the least possible compensation. So the lumbar lordosis has to be within the pelvic incidence angle plus or minus 9. We have to have a small pelvic tilt as a sort of a compensation, less than a 20 degree. And the central vertical axis has to be less than a 5 centimeter off the lumbosacral articulation, and no hip, no knee flexion. So we do that by breaking the spine into two parts. We do that on a table that is bent, and then we correct the table and then close that corrective osteotomy and then fix it. The type of osteotomy, we think about it based on a clinical and radiological evaluation. So the type of osteotomy can be done based on the type of imbalance. So type 1 imbalance, where they have a hypokyphosis as a sort of a spine compensation, you could see in this view, is called type 1. Type 2, when there's no enough compensation can be made, so the patient is completely off balance. So we look at the parameters clinically and radiologically and see the type of the deformity. Is it smooth, sharp? And we pick it which side is more significantly involved, thoracic, lumbar, or even cervicothoracic, and we pick the type of osteotomy. The initial evaluation has to be made for the nutritional condition and the patient, and is he ready for this major procedure. Patient who has a cervicothoracic where their head is not aligned well, they would have a problem with the swallowing. So the nutritional status is usually behind. So proper feeding, whether it's enteral or parenteral, and optimizing their nutritional status before the surgical management is important. The use of NSAIDs is not something good to be utilized during the fracture healing or even following the osteotomy for correction of a deformity due to high risk of non-union or failure of fusion. So please hold any non-steroidals for these kind of cases who's going for a surgical management. So the type of osteotomy, the simple one is called Smith-Peterson osteotomy. We simply get that osteotomy by resecting the posterior element of the spine and close that gap, usually about 1 centimeter gap. We resect the whole flavum as well in order to free the neural tissue, avoid buckling it. This was described in 1945 for ankylosing spondylitis, but this does work in the early stage when you have the disc still mobile, but an advanced stage is not helpful at all. It can be helpful in another disease also, like Sherman disease. This is an example of multiple level osteotomies that was performed with a good correction of the alignment following the osteotomy. More advanced osteotomy is called pedicle subtraction osteotomy and even vertebral column resection, where we could do to get a better angle correction. We usually select the segments to be done at the lumbar spine, but it can be done anywhere in the spine, but higher risk of possible neurological deficit. The good level, usually we pick it at the level of the L3-4 level. We resect the posterior element of the spine, followed by creating a wedge osteotomy through the vertebral body, and then we close that gap with the instrumentation and correction of the deformity. This is an example of a patient who's been through a pedicle subtraction osteotomy. The whole alignment is off. You can see the central vertebral line is completely to the front, more than 10 centimeter. and the pelvis is retroverted, the hip is extension, the knee inflection, and the thoracic in hypokyphosis. So following the correction, the whole parameters improved, and even the hip became more vertically oriented, and the knee is in extension with a good lumbar lordosis. In cervicothoracic, we could get the same problem, but more complex way to handle, because we need to cut the posterior element of the spine and create a wedge fracture through the body and then correct the whole alignment. This procedure is still doable, but takes a higher risk compared to the previously described one because its location at the cervicothoracic. In conclusion, ankylosing spondylitis is a progressive disease that is affecting the alignment of the spine, and the deformity can lead to difficulty with the horizontal gaze and the ambulation and activity of daily living. Identification of a fracture case is extremely important, and immobilizing it in a pre-injury condition to avoid possible uh, injury to the neural tissue around that fracture is extremely important till the definitive management is made. Reconstruction of a deformity and correcting the alignment is a procedure that is described for many patients who's indicated, and the patient has to be oriented about the benefit and risk and benefit of such a procedure with a good understanding of the expectation and be objective with the outcome, usually can give them a significant improvement in their quality of life. Thank you very much for listening.